Meningitis day-to-day Wilfrit, MD Pediatric Infectious Diseases. Duke University Medical Center. Meningitis. Meningitis, inflammation of the membranes that surround the brain and spinal cord, the dura mater, arachnoid mater, and pia mater. Encephalitis, inflammation of the cerebral cortex. Meningoencephalitis, inflammation of the meninges and the cerebral cortex. Pathogenesis bacteria virus. Maternal genital secretions or nasopharyngeal colonization. Mucosal invasion and penetration into the bloodstream. Hematogenous spread through the BBB, choroid plexus, or direct inoculation. Virus. Upper respiratory tract or gastrointestinal tract. Primary viremia. Proliferation in other organs, lymph nodes, liver, spleen. Secondary viremia through the BBB. Chavez Bueno S. Pediatric NM52 795 to 810. Pathogenesis inflammation within the subarachnoid space. Cell wall or membrane components. Gram-positive, peptide dog-glycan. Gram-negative, lipopolysaccharides. Inflammatory mediators. TNF-alpha, IL-1, IL-6, IL-8, IL-10, No, prostaglandins, and macrophage-induced proteins. Cerebral edema, increased ICP, and toxic oxygen radicals causing apoptosis. Chavez Bueno S. Pediatric NM52 795 to 810, neonatal meningitis. Patient is a 3 weeks old formerly full-term, vaginal delivery who presents to the ED. He has been irritable throughout the day with poor feeding throughout the day. 1 hour prior to arrival, he developed a rectal temperature of 100.6 F. In the ED he appears fussy and difficult to console, but otherwise stable. On physical examination he has a temperature of 101 F, a flat fontanelle, no nuchal rigidity, and no Kroning's nor Brudzinski sign. Neonatal meningitis incidence 0.25 to 1 per 1,000 live births. Risk factors. Perinatal and intrauterine infection, T greater than 100.4 OC, prolonged rupture of membranes, greater than 18 hours, prematurity, less than 37 weeks, low birth weight, previous infant with GBS disease, maternal urinary tract infection. Early and late onset meningitis. Neonatal sepsis arises less than 1%. Meningitis 25% of septic neonates. 1% of lumbar punctures. Clinical manifestations, neonate. Signs and symptoms incidence, %. Temperature instability 60. Fussy, lethargy 60. Poor feeding and vomiting 48. Seizures 42. Respiratory distress 33. Apnea 31. Bulging fontanelle 25. Diarrhea 20. Nuchal rigidity 13. Signs of meningitis are often subtle in the neonate. Classic symptoms of meningitis not until 18 to 24 months. What laboratory studies would you order? CBC with differential. Electrolytes and LFTs. Urinalysis. Cerebrospinal fluid. WBC with differential. RBC. Protein. Glucose. Gram stain. Blood culture. Urine culture. CSF culture. Viral culture CSF and surfaces. HSV and enterovirus PCR. Is this consistent with meningitis? Laboratory results. CBC, WBC 8000 cells/M3, and 60% B 10% length 23%, HH 11.2, 30 and platelets 150,000. Electrolytes, CO2 18 and glucose 80, LFTs normal. Urinalysis, protein 1+, ketones 1+, nitrites neg, neg, WBC 1, RBC 0, bacteria 0 to 5. CSF, WBC 120, P 80% length 10% M 10%, RBC 5, protein 240, glucose 30. Is this consistent with meningitis? Cerebrospinal fluid, neonates. Normal cerebrospinal fluid of neonates and children. CSF study. Premature infants. Term to 7 days old. Term 8 to 30 days old. Term greater than 1 month old. WBC, UL. 0 to 21. 0 to 6. Neutrophils, UL. Less than 40 to 60%. Less than 50 to 60%. Less than 20%, 0 to 2. RBC, UL. 0 to 2. 0 to 2. Glucose, mg/dl. 30 to 100. 35 to 80. 40 to 80. Protein, mg/dl. 45 to 200. 20 to 140. 15 to 100. 10 to 45. Evaluated 9,111 neonates greater than 34 weeks gestation to establish concordance of CSF culture, CSF parameters, and blood culture and culture-proven neonatal meningitis. 38% of neonates with culture-proven meningitis had a negative blood culture. Peripheral WBCs were neither sensitive nor specific for bacterial meningitis. Due to the variability in CSF parameters, unable to develop an algorithm to accurately and precisely predict meningitis based on CSF parameters alone. 10% of neonates with bacterial meningitis had less than 3 CSF WBCs/M3. A threshold value of 21 cells as the upper limit of normal would have missed 12.6% of meningitis cases. Meningitis can occur in the presence of normal CSF WBC, protein, and glucose levels. Culture results: gram-stain gram-positive cocci in pairs, chains. CSF culture group B Streptococcus. Blood culture negative. Urine culture negative. Virus culture, cancelled after gram-stain positive. And high-S valent. Enterovirus PCR. What are the most common organisms that cause bacterial meningitis in neonates? Group B Streptococcus, 30 to 40%. Gram-negative enteric bacilli, 30 to 40%. Escherichia coli, Klebsiella, Enterobacter, Salmonella, Serratia marcescens, Citrobacter, and Proteus mirabilis. Listeria monocytogenes, 10%. Others include Staphylococcus aureus, viridins streptococci, and coagulase-negative staphylococci. What antibiotics would you empirically start? Ampicillin plus an aminoglycoside or sfotaxim. Infants, greater than 1 month. Vancomycin plus sfotaxim. Specific therapy organism antibiotic duration GBS. Sensitive penicillin or ampicillin 14 to 21 days. L-monocytogenes ampicillin plus aminoglycoside 14 to 21 days. Gram-negative third cephalosporin 21 days. Enteric organisms plus aminoglycoside 14 days after negative. Staphylococcus. Sensitive nafcillin or oxacillin 21 days. Resistant vancomycin plus rifampicin. Neonatal complications. Development delay 26%. Hydrocephalus 24%. Ventriculitis 20%. Late seizure 19%. Cerebral palsy 17%. Brain abscess 13%. Hearing loss 12%. Subdural effusion 11%. Cortical blindness less than 10%. Mortality 15 to 20%. Meningitis. Patient is a 4-year-old Hispanic male without past medical history who presents to the ED. He complains of fevers, D103.8F, headaches, photophobia, neck stiffness, vomiting, myalgias, and drowsiness over the past 24 hours. On physical examination, he is febrile, T102.4F, but vitals are otherwise stable. He is alert and irritable, but able to cooperate with the examination. He is without focal neurologic signs and there is no rash. What would you look for on physical examination that is specific for meningitis? Nuchal rigidity. Kernig's sign. Brudzinski sign, Kernighan-Brudzinski sign. Kernighan-Brudzinski sign present 5% of adults with meningitis. Nuchal rigidity present in 30% of adults with meningitis. What laboratory studies would you order? CBC with differential. Electrolytes and LFTs. Cerebrospinal fluid. Opening pressure. WBC with differential. RBC. Protein. Glucose. Gram stain. India Inc., cryptococcal antigen of immunocompromised. Blood culture. CSF culture. Viral culture CSF, nasopharyngeal, and perirectal. Enterovirus PCR. Would you order a head CT prior to the LP? Head CT should be performed if signs of increased intracranial pressure on physical examination and should not result in delay of blood tests nor start of antibiotics. Abnormalities detected on CT scan were already suspected by neurological examination and did not affect clinical management. Signs of increased intracranial pressure. Focal neurologic signs, altered level of consciousness, bradycardia, hypertension or hypotension, and altered respiratory pattern, papilledema late sign. Cabral D.A. J. Pediatra 1987 111-201. Laboratory results. CBC, WBC 21,000 cells/M3, N 70% B 5% length 15%, HH 14, 36 and platelets 470,000. Electrolytes, glucose 70, and LFTs normal. CSF, cloudy, WBC 1400, P 80% length 10% M 10%, RBC 120, protein 180, glucose 20. Bacterial versus aseptic meningitis. Bacterial meningitis. Meningitis caused by identified bacteria. Peak in the fall and winter. Aseptic meningitis. Meningitis not caused by identified bacteria. Most common type of meningitis. Peak in the late spring to fall. Biphasic fever, especially with enteroviruses. Cerebrospinal fluid. Typical cerebrospinal fluid findings component. Bacterial meningitis. Viral meningitis. Herpetic meningitis. Tuberculous meningitis. Leukocytes, MCL. Greater than 1000. Less than 100. 10 to 1000. Cells. Neutrophils. Lymphs. CSF, serum glucose. Normal, low. Normal. Low. Protein, Mg/dl. Greater than 100. 50 to 100. Greater than 75. Greater than 100. Erythrocytes, MCL. 0 to 10. 0 to 2. 10 to 500. Cerebrospinal fluid. Bacterial meningitis. Viral meningitis. WBCs greater than 1000 cells/M3 with neutrophil predominance greater than 80%. Early infection can have a lymphocyte predominance in 10% of patients with WBCs less than 100 cells/M3 than neutrophil predominance at 48 hours. Neutrophil predominance related to bacterial meningitis but no threshold of clinical significance, and 90% equals ppb 25%. Viral meningitis. WBC less than 100 cells/M3 with lymphocyte predominance. Early infection neutrophil predominance, 59%, with WBCs greater than 1000 cells/M3 than lymphocyte predominance after 24 hours. During the peak season for aseptic meningitis, a patient with neutrophil predominance is more likely to have aseptic meningitis than bacterial meningitis. Negrini B. Pediatrics 2000 105 to 316. Culture results. Gram stain. Gram-positive cocci in pairs, chains. CSF culture. Streptococcus pneumoniae. Blood culture Streptococcus pneumoniae. Viral cultures negative. And enterovirus. PCR. Cerebrospinal fluid gram stain sensitivity bacterial culture. S. pneumoniae 90%. H. influenza 86%. N. meningitis 75%. Gram-negative bacilli 50%. L. monocytogenes 33%. Specificity greater than 97%. Bacterial culture. Sensitivity 70 to 85%. CSF is uninterpretable. Traumatic tap. CSF is uninterpretable. CSF contaminated with blood in up to 20% of taps. Both underdiagnose and overdiagnose bacterial meningitis. Repeat lumbar puncture after 48 hours. Rules: 1 WBC/M3 for every 500 to 1000 RBC/M3. WBC, CSF, equals WBC, CSF, dash, WBC, BLD, XRBC, CSF/RBC, BLD. Bonsubike. Pitch 2006 25-8. Partially treated meningitis. Up to 50% of cases may initially receive oral antibiotics. CSF WBCs, protein, and glucose generally remain abnormal for at least 44 to 68 hours after antibiotics. CSF sterilization and meningitis within 1 to 2 hours. S. pneumonia within 4 hours. Gram stain sensitivity till to 20% lower. Feigen Road Textbook of Pediatric Infectious Diseases 4th ed. 1998. Canagape J.T., et al. Pediatrics 2001 108 to 1169. Partially treated meningitis. Latex agglutination. Detects bacterial capsular antigens, thus results are not affected by prior antibiotics. Low ppv and MPV. A positive or negative latex agglutination does not change clinical therapy or hospital course. Polymerase chain reaction. Enterovirus and herpes simplex virus. Sensitivity and specificity greater than 90%. Presumed bacterial meningitis. Treat at least 10 days. Hayden Arty. Pitch 2000 19 to 290 to 2. Uncle R. IDSA Guidelines Meningitis. SID 2004 39 to 1267. Of pre-treated children, gram stain was positive in 60% and latex agglutination was positive in 42%. Latex agglutination test did not identify any pathogen that was not identified by blood or CSF culture. Of culture negative, pre-treated children, none were positive by latex agglutination. Negative latex agglutination test did not decrease the risk of bacterial meningitis. Nigrovikla, et al. Pitch 2004 23 to 786. What are the most common organisms that cause bacterial meningitis in this age group? Streptococcus pneumoniae. 4, 6b, 9, 14, 18f, 19f, 23f. Neisseria meningitis. B, C, Y, W135. Haemophilus influenza type B. Viral meningitis enteroviruses, Coxsackie and echoviruses. Arboviruses, St. Louis, Western, and Eastern Equine, West Nile, California, La Crosse, viruses. Herpes viruses. Mumps virus. Human immunodeficiency virus. LCMV. Respiratory viruses, adenovirus, rhinovirus, influenza virus, parainfluenza virus. Kumar R. Indian J. Pediatra 2005 7257. Aseptic meningitis, infectious. Bacteria. Partially treated. M. tuberculosis. M. pneumoniae. C. pneumoniae. Ehrlichiosis. B. Burgdorferi. T. pallidum. Brucella. Leptospirosis. Fungi, C. neoformans. H. capsulatum. Coccidioides, Blatomyces dermatitides. Candida. Parasites. Toxoplasma gondii. Neurocysticercosis. Trichinosis. Naegleria. Bartonella Hensley. Rickettsia. RMSF. Typhus. Kumar R. Indian J. Pediatra 2005 7257. Aseptic meningitis, non-infectious. Post-infectious, post-vaccinal. Drugs. Systemic diseases, rheumatologic. Neoplastic diseases. Parameningeal inflammation. Kumar R. Indian J. Pediatra 2005 7257. What antibiotics would you empirically start? Vancomycin. Third-generation cephalosporin. Ceftriaxone or sfotaxim. PICU admission and ID consult. Definitive meningitis. Positive CSF gram stain for bacteria. Probable meningitis. Age less than 6 months and CSF WBC greater than or equal to 100 and low glucose in CSF, or CSF WBC greater than or equal to 500 or CSF WBC elevated for age and greater than 70% neutrophils or CSF WBC elevated for age and localizing neurologic exam, regardless of age or CSF WBC elevated for age and one risk factor. Seizures. Altered mental status. Hypotension or hemodynamic instability. Age less than 12 months and not vaccinated. Immunocompromised, for example sickle cell, egg deficiency, HIV. Specific therapy organism antibiotic duration S. pneumoniae. MyPCN less than 0.1 penicillin G or ampicillin 10 to 14 days. MyPCN 0.1 to 1.0 third-gen cephalosporin. MyPCN greater than 2 vancomycin. MyCef greater than 1.0, plus third-gen cephalosporin. Rifampicin. And meningitis. Myc less than 0.1 penicillin G, ampicillin 7 days. Myc 0.1 to 1.0 third-gen cephalosporin. H. influenza. Sensitive ampicillin 7 to 10 days. Resistant third-gen cephalosporin. Uncle IDSA guidelines meningitis. SID 2004 39 to 1267. Specific therapy organism antibiotic duration. Gram-negative third-gen cephalosporin 21 days or enteric organisms plus aminoglycoside 14 days after negative. Pseudomonas ceftazidime, carbapenem. Ticarcillin, piperacillin. Plus aminoglycoside. S. aureus. Meth-sensitive nafcillin or oxacillin 21 days. Meth-resistant vancomycin and rifampicin. Enterococcus. Sensitive ampicillin plus aminoglycoside 14 to 21 days. AMP-resistant vancomycin plus aminoglycoside. Vanc-resistant linezolid plus aminoglycoside. Uncle IDSA guidelines meningitis. SID 2004 39 to 1267. Neurosurgical condition organism antibiotic. Bacillus skull S. pneumoniae vancomycin plus. Fracture H. influenza third-gen cephalosporin. S. pyogenes. Penetrating S. aureus, co-NS vancomycin plus FIM. Trauma gram-neg bacilli ceftazidime, or meropenem. Post-neurosurgery gram-neg bacilli vancomycin plus FIM. S. aureus, co-NS ceftazidime, or meropenem. CSF shunt co-NS, S. aureus vancomycin plus FIM. Gram-neg bacilli ceftazidime, or meropenem. P. acnes. Uncle IDSA guidelines meningitis. SID 2004 39 to 1267. Steroids dexamethasone. Decrease inflammatory mediators associated with worsening of morbidity and mortality, Deafness and nerve damage. Decreased penetration of antibiotics into the CSF, vancomycin. Mask fever and rebound fever after discontinuation. Recommendations: prior or with first dose of antibiotics. Haemophilus influenza beneficial effect, hearing loss. S. pneumonia possible effect, for infants and children 6 weeks of age and older. Adjunctive therapy with dexamethasone may be considered after weighing the potential benefits and possible risks. And meningitis no supporting data. McIntyre P.B., et al. JAMA 1997 278 to 925. OP Committee on Infectious Diseases 2003. Tunkelar, et al. SID 2004 39 to 1267. All S. pneumoniae were susceptible to penicillin. Reduction in risk of an unfavorable outcome, RR, 0.59, 95% C, 0.37 to 0.94, P equals 0.03, and mortality, RR of death, 0.48, 95% C, 0.24 to 0.96, P equals 0.04. No beneficial effect on neurologic sequelae including focal neurologic abnormalities and hearing loss. Chemoprophylaxis, meningococcus. High risk, chemoprophylaxis are recommended. Household contact, childcare or nursery school contact, direct exposure to index patients' secretions, kissing, toothbrushes, eating utensils, mouth-to-mouth resuscitation, unprotected contact during endotracheal intubation. Frequently slept right in same dwelling, passengers seated directly next to the index case during airline flights lasting more than 8 hours. Low risk, chemoprophylaxis not recommended. Casual contact, no history of direct exposure to index patients' oral secretions, e.g., school or work. Indirect contact, only contact is with a high-risk contact, healthcare professionals without direct exposure to patients' oral secretions. In outbreak or cluster. Chemoprophylaxis for people other than people at high risk should be administered only after consultation with local public health authorities. Red Book 27th ed. 2006. Chemoprophylaxis, meningococcus. Age, dose, duration, efficacy. Rifampicin. Less than 1 mO 5 mg/kg Q12 2 days. Greater than 1 mO 10 mg/kg Q12 2 days 90 to 95%. Max 600 mg. Ceftriaxone. Less than 15 yo 125 mg single dose 90 to 95%. Greater than 15 yo 250 mg single dose 90 to 95%. Ciprofloxacin. Greater than 18 yo 500 mg single dose 90 to 95%. Red Book 27th ed. 2006. Chemoprophylaxis, Haemophilus. High risk, chemoprophylaxis are recommended. For all household contact in the following circumstances: household with at least one contact less than 4 years of age who is unimmunized or incompletely immunized, household with a child less than 12 months of age who has not received the primary series, household with a contact who is an immunocompromised child, regardless of that child's Hib immunization status. For nursery, school and child care center contacts when 2 or more cases of Hib invasive disease have occurred within 60 days. Chemoprophylaxis not recommended. For occupants of households with no children less than 4 years of age. For occupants of households when all household contacts 12 to 48 months of age have completed their Hib immunization series and when household contacts less than 12 months have completed their primary series of Hib immunizations. For nursery, school and child care contacts of 1 index case. For pregnant women. Red Book 27th ed. 2006. Meningococcal vaccines. Menimmune, MPS v4. Licensed in 1981. Greater than 2 years old. Protection 3 to 5 years. Recommendations. High-risk groups, 2 to 10 years old. Functional or anatomic. Asplenia. Terminal C or Properdin. Deficient. travel to areas where meningococcus is epidemic. Menactra, MCV4. Licensed in 2005. 11 to 55 years old. Protection at least 10 years. Recommendations. High-risk groups, greater than 10 years old. 11 to 12-year visit. High school entry or 15 years old. College students living in dorms. A, C, Y, W 135. Red Book 2006. Swartz M.N. Name 2004 35118. Prognosis mortality rate, 4 to 10%. Infants and children less than 5%. Streptococcus pneumoniae 10%. Neisseria meningitis 3 to 5%. Haemophilus influenza 3 to 5%. Factors associated with a poor outcome. Extremes of age. Hypotension. Altered mental status. Seizures. S. pneumoniae, GBBS, gram-negative bacilli. High bacterial burden. Delayed sterilization of CSF. Low CSF glucose, less than 20 mg/dl. Chavez Bueno S. Pediatriclin and Amer 2005 52 to 795. Neurologic sequelae sensory neural hearing loss cranial nerve palsies. S. pneumoniae 20 to 35%. N. meningitis 5 to 10%. H. influenza 5 to 10%. Cranial nerve palsies. Vascular insults, hemiparesis. Seizures. Hydrocephalus. Ataxia. Diabetes insipidus. Behavior disorders. Learning disabilities. Chavez Bueno S. Pediatriclin and Amer 2005 52 to 795.